Good morning and welcome to today's Lunch and Learn. My name is Michelle Snow. I'm Patient Education Librarian here at Princess Margaret Cancer Center, and I will be introducing our speakers today. They will be talking all about the dental clinic at Princess Margaret and what they can do for patients in the clinic. We have speaking today Dr. Bob Wood, who's Chief of Dentistry in the Department of Dental Oncology, Ocular and Maxillofacial Prosthetics, Princess Margaret Cancer Center, and he's also Associate Professor at the Faculty of Dentistry, University of Toronto. We also have speaking today Dr. Linda Lee. She's an active staff dentist since 1989. Dr. Lee is a certified specialist in oral pathology and oral medicine, and she's also an Associate Professor at the Faculty of Dentistry, University of Toronto. So please join me in welcoming our guests today.
I think it's just too beautiful a day to be inside for lunch, isn't it? Okay, so today we're just going to talk to you a little bit about what we do in the dental clinic. The dental clinic was established at Princess Margaret about 1983 at the old site, and we moved down with the rest of the hospital in 1996, or 5 or 6 or so. Okay, so who are we? There are 2 full-time dentists, actually Dr. Wood and Dr. Maxmew. I was full-time up until this year, and I've gone part-time on my way to retirement. We have 7 part-time dentists, and most of the part-time dentists are specialists. Okay, so Dr. Almardini is a maxillofacial prosthetist. Dr. Burgess is an oral pathologist, and she actually runs our screening clinic for suspicious lesions. That clinic actually runs in the Wharton Head and Neck Clinic in conjunction with the ENT, and she takes referrals from dentists and physicians for patients who have suspicious oral lesions, but they're only coming from other medical health care. Dr. Sun Watson are general dentists that do a lot of the general dentistry in our department. Dr. Chadwick's an oral radiologist, or soon to be oral radiologist, and Dr. Lamb is an oral surgeon. We have 2 hygienists who make up 1 full-time equivalent, and they do all of our checkups and cleanings. We have an ocularist and a plastologist, Daphne Archibald, so she makes eyes and other parts of faces that are removed because of cancer. And we have a full-time registered dental technician. Okay. So, who do we serve? Our patients, since 1984, we've had a database, and we have seen over 29,000 different patients. About 40% of them are in preparation for head and neck radiation. Another 40% are in preparation for autologous and allogeneic bone marrow transplants. About 10% are surgical patients, and 10% are other cancers. So that patients who are coming to the hospital for chemo or for other radiation treatments, if they have a toothache or a dental problem and their dentist is worried about seeing them, their oncologist can refer them to us, and we can do an emergency care. Okay, so what do we do? Our bulk of our role is to prepare patients for cancer treatment. Now, that involves education, sometimes extractions, fillings, cleanings, and importantly, fluoride care, emergency care during treatment, help to manage the complications of treatment, and rehabilitation of oral function. Now, our clinic was first established because of the head and neck site group's needs. Because of the serious complications that can arise from radiation to the head and neck, especially to the mouth area, they actually supported us in getting going so that we could see their patients before to help prevent them. And actually our center, because of that, has one of the lowest rates of osteoradionecrosis, which is a really serious side effect, because we see the patients before. So our first relationship was with the head and neck site group. So when we say head and neck cancer, what do we mean? Mostly they are skin type of cancer, so it's the lining of the mouth. That means the tongue, the gums, the buccal mucosa inside the cheeks All of these areas are at risk of getting cancer, okay? It can be in the throat, nose, sinuses, nasopharynx, and sometimes patients present with a lump in their neck and it has spread from somewhere in the head neck area to a lymph node in the neck. In North America, head and neck cancers only account for about just under 5% of all cancers. So it's not a great amount when you think about breast being 25% or prostate being 25%. But these have very high quality of life factors because of people's ability to eat and speak, or their problems with that because of their treatment. So I'm going to spend some time just on the head and neck because that's really what we do, what we were here for most and what takes up most of our time. If you just look at the age and sex distribution of that patient group, you can see that it affects males much more commonly than females and in the 5th to 6th decades of life. This is probably because there are more females living than males, and that's why there's more females at that age range. But it's very rare at this time. So our head and neck cancer patients are traditionally people who smoke and drink, because alcohol or tobacco for sure is one of the big risk factors for oral cancer. Add to that alcohol abuse, then they're at even a higher risk. Now, these types of patients aren't necessarily the kind of patients that like to go to dentists. So we've got a very select patient population. People who smoke and drink aren't necessarily people who go to physicians or dentists, and most of the time they say they hate dentists, they don't like going to the dentist, and that makes our job even harder. So what do? Patient comes in, the first thing we do is we take a panoramic dental x-ray. That's one that goes right around the head, and it shows all the teeth and the jaw bones and the sinuses. We take a medical history and find out if they have other medical comorbidities, and we also find out their history of the cancer and how long it's been there and how it has been affecting them. We look at all their teeth, and we go over in detail all the side effects of the radiation treatment. We perform routine dental care, and then we make them fluoride trays. Now, the dental examination, what we do is we check for cavities, we check for loose teeth, we check for bad fillings and things like that. The big thing is that with radiation, the side effects are permanent. So we have to make sure that the patients understand that they have to take good care of their teeth forever. So this is a typical head and neck patient. Okay, haven't been to a dentist this century. That's what I ask when they say they haven't been for several years. I'll say, well, have you been this century? No, they don't brush their teeth. They don't take care of things. So now we have to try to get them in good health, oral health, in order to get them ready for their treatment. So you can just see there's, they've never been to a dentist. They don't, lots of junk on their teeth to clean. But then when we take x-rays, and I know you're not radiologists or anything, but you can see that the crown's missing from this tooth. This is an abscess here. These teeth are broken off and rotten. There's a big cavity there. There's gum disease. These teeth are all loose. So because of the side effects of radiation, this patient may have to lose all their teeth prior to even starting the radiation. So that's a big stress on them. They've just found out they have cancer, they're going to have radiation, and now you're going to pull out all my teeth? Yes. So it's very difficult on the patient. It is difficult on us. It's very stressful for us because we don't have facilities to put people to sleep. This is done under local anesthetic, and it might, if they're starting their radiation next week, it has to be done now so it can heal before then. So it's a very traumatic experience for all involved. So here's another typical head and neck patient. Wisdom tooth's broken off. This is a big cavity. This is a big cavity. This tooth is broken. This has got a big cavity. There's nothing holding this tooth in. We try to make a determination based on where the radiation field is, whether they can keep their teeth or not. So if, for example, this patient's primary site was a thyroid or very low in the neck, the radiation may not affect the bone so much, and we're not as aggressive as taking out their teeth. If, for example, there are cancers in their tongue, we know that all of these are going to get radiated, which means that there's going to be damage to the bone, which means that you cannot take teeth out in the future without causing a lot of problems. So it's very difficult to explain to a patient that in 10 years' time, if you need to have a tooth pulled out, you could get gangrene just because you didn't take care of it. Again, another case where the teeth there's huge cavities, teeth broken off, another cavity. I mean, patients know. They know that when they smile, there's no teeth there. They know their teeth are bad. Why haven't they done anything? Well, they're afraid. It's just for the same reason why they didn't go to the doctor when they felt this lump or had this sore. So they're very difficult patients to deal with. So the teeth that we are leaving behind, we have to make sure that they don't get cavities, and we have to make fluoride trays for them. Now, part of the side effects of radiation is a dry mouth. And your saliva does a lot of things for you. We always take it for granted. Your saliva helps food digest. It's got enzymes that melt food in your mouth. It makes food slippery so you can swallow. But the most important thing for your teeth is that the saliva is always washing your teeth 24 hours a day in a buffer solution that neutralizes acid. So anyone with a dry mouth, even if it's not from radiation, is at risk of getting a lot of cavities because there's a lot more acid in the mouth. So these are fluoride trays. They're just like the mouth guards that hockey players and boxers wear. They're soft, flexible. We make them custom made to go in the patient's mouth. They put the fluoride in the tray and put it on their teeth for 5 minutes a day. And if they do that faithfully, they shouldn't have any problems. Okay, now let's talk about some of the side effects from radiation. We all know you get this brisk erythema, so the skin turns red. It also turns red in the mouth. Okay, so mucositis, just this generalized whitening of the tissues. There's some ulcerations here. Here are some more ulcerations here. So during radiation, when this happens, it makes it very difficult for people to eat. So they may be on feeding tubes. When you're on feeding tubes, your teeth even are in worse shape because by eating, you actually clean your teeth. So it actually gets compounded. Now this white or yellow area here and here, these are all just raw open sores. And you can imagine, I don't know if any of you get a canker sore, a little canker sore, how much it bothers you. If you have these huge sores in your mouth, you can imagine how difficult it is to eat. Which means they're going to be slower to heal. Okay, so the other thing, dry mouth, this is a permanent change. They get a coated tongue and have an increased risk of cavities. Now this man has also had surgery, so part of his tongue has been replaced, but you can just see how dry the mouth is. And when your mouth is dry, the little papillae on your tongue pick up all kinds of dead skin and bacteria, and you get this coated, what we call a hairy tongue. And if you keep on smoking, the hairy tongue turns brown or black. Okay. Now, damage to the teeth. Okay, so these teeth, all this white change is acid etching the enamel. Okay, so normally the enamel's, like this one is okay, it's nice and smooth, but if you put a tooth in a vat of acid, this is what starts happening. It usually happens around the gum line because that's where food collects, especially in a dry mouth. So all of these white areas are early decalcification. And then they start turning brown as they become cavities. There's some bleeding there because I was just going to fix these and then did some freezing. So cavities happen at the gum line. They happen at a very narrow part of the tooth. And that means that a smaller cavity can make the tooth break off. And then they get worse. So this is in someone who hasn't used the fluoride, okay? If they use the fluoride, this is not going to happen. So we actually have pictures like this in our operatories in the dental clinic to encourage people to use the fluoride. Because when they stop using it, this is what's going to happen. Now, patients will say, well, who cares, they're just cavities, pull out the teeth. Well, we can't pull out the teeth, okay, because of this serious complication, osteoradionecrosis. This is a complication of poor healing in radiated bone. So bone is damaged by the radiation, and it can't respond well to trauma or healing or tooth extraction, okay? So what happens is the bone actually sticks out. So this is a man who had a denture made after radiation, and the denture caused a sore, and the sore went down the bone. This one. So here's a later case where the whole inside of the mandible is exposed. Now, at this stage, this is basically gangrene. There's not much you can do about it. If you tell the patients, and I try to tell them, look, if this is, it could turn into gangrene if you don't use your fluoride, they understand that gangrene means amputation. Okay, and it's a very big operation where they take a piece of your leg and with the skin on it and cut this out and put it in there. So it's worse than a cancer operation treating this. This patient came in and she said, oh, her tooth fell out. And this is the bone that's left behind. So sometimes if we have to take a tooth out after radiation, and sometimes we do, there's not a drop of blood. And you can imagine that that's going to fill up with food and bacteria and not heal. So if we can prevent doing that, that's where the patient education comes in. That's where we reinforce the patient every single time they come in. Are you using your fluoride? You cannot have a tooth pulled out. And we have pictures of these up in the clinic as well, so that it will help encourage. Now, what happens if you leave it? You break your jaw. Now, in this case, sometimes they can put in a graft, but in this case, they just cut off the jaw and left it hanging there. And she has a really hard time. She can't eat because her jaw swings all over the place. And, 5 years, or well, she was actually about 10 years ago, she never used her fluoride trays and had to have all her teeth pulled out. Okay, so what I'm trying to get at, what we try to explain to the patients is that most dental problems are preventable. So if we can make sure that the patients understand this and that they can take good care of their teeth, that they're seeing a dentist on a regular basis, or that they're seeing us on a regular basis, they can prevent it. Any questions about the head and neck patient? So we follow them. So we see them halfway through radiation, we see them 1 month after, we see them 6 months after, and then we see them every 6 months if they don't have their own dentist. But sooner if they start getting cavities and running into problems. Often people will say, oh, but I've been using the fluoride, and you can tell that their teeth aren't clean. So, well, the teeth have to be clean or the fluoride's not going to get to the cavity. It's not going to get to the right spot. So we have to go over that too. Yes?
I want to know what's the healing time required if you need to do a major extraction before they start radiation?
Anywhere from 1 to 2 weeks is optimal, but sometimes because of increased workload, and right now, we're, how many patients do we have?
2.
Yeah. If we can't see them right away, sometimes they're starting their treatment tomorrow, and we have to do it right now. Or we try to delay their treatment, and no one likes to have their cancer treatment delayed.
It depends on the patient too. I mean, if your patient's healthy and so let's say they're starting radiation on a Thursday, as opposed to someone who's not healthy and starting the next day. There's when people ask me how long things like that take, I always ask them how much my dog weighs, because they ask me good questions, but just like they've never seen my dog, I've never extracted their teeth and see how long it takes for them to heal. So I actually have a picture of my dog in the upper trying to actually make them guess at how much my dog weighs. They're always wrong, so it's a good teaching tool. But it's a good question, but it's it depends. What are their other comorbidities? What's their level of health? And things like that.
I guess just in terms, like is there a minimum number of days we should wait before they start radiation if they have to remove like 10
Yeah, that's another, how much is my dog weight question? How much is my cat weight? And all that.
Yeah,
It's a great question, but, like we do delay treatment sometimes. We'll speak to the radiation oncologist and say, look, this guy, and also the number of teeth. If we're doing one extraction, or if we're doing extractions that anybody would agree with me in the upper jaw, I don't really worry. But extractions, except with nasal fossa, but in the lower jaw is 2 sheets of plywood with a little bit of bone between it, so it's going to take a long time to heal. So a little bit more careful in the lower jaw, and we try to do things atraumatically. Until we get too many patients, then we just go at it.
You seem to mention that the surgery is limited here. Is it done across the road, or?
It's the oral.
Oh, it's basically the booking time. To put someone to book, if you wanted to have all your teeth pulled out, you went to an oral surgeon. They'd say, okay, I've got OR time in 2 months. Okay, I can do that. So yeah, we could do that too in 2 months. But it's because it's like OR time when you have to put someone to sleep.
Yeah.
And that in hospitals is very hard to come by, especially for dentists.
Right. And the other issue is that for an oral surgeon, they don't want to see our patients because they're not economically remunerative. So they can sink an implant. I've done implants. You can sink an implant in 15 minutes, like putting a drywall plug in the wall. It's $2,500.
Oh.
That's part of the equation too. Like, we just they can't be seen anywhere else, unfortunately.
Yes.
So I was just wondering then, like, is this type of dental care covered
No.
by patients?
Except extractions.
Only the extractions are covered. So if they need fillings, the fluoride, they're not covered.
This is the mantra.
And so we try to explain that to patients too. We don't deny anyone treatment.
Yeah.
So if you need to have it done, we'll say,
Yeah.
the fluoride trays are going to cost $250. You can pay us $50 a month.
We don't charge interest. If patients are ill and they can't work, we hope we don't even charge until after they're well. But I always tell people that the government only pays to destroy. So if you need something taken out, you're laughing. But if you need something built up, because there's a reason that dentistry is not covered by OHIP, and that's because we would bankrupt in 3 weeks, the dentist of the province. Because a bridge is like $3,500. An implant retained crown is $5,000. We couldn't possibly do that on patients, because it's just way too expensive.
Just wondering if you've experienced anything with hyperbaric oxygen therapy in terms of the healing, whether it improves it before or after?
Yeah, we've used it a lot, and it really doesn't work.
You know what? It's
good for soft tissue, but for bone, it's really.
You can't make
Yeah, there's just no.
dead horse get up.
There's just not
it is
much
useful.
supply.
I think for pain.
Yeah.
I think it's useful for some from pain and glow and some other stuff that will be used.
Okay, for the bone marrow transplant patients, first of all, these patients tend to be a bit younger and I want to say cleaner. But really, the reason we're seeing them is because the high-dose chemotherapy is going to suppress their immune system, causing an increased risk of infection and risk of bleeding. So what we're doing with these patients is, again, trying to predict the future. Are you going to have an infection while you're in isolation? Are you going to have a third molar or a wisdom tooth blow up and get infected and then get sepsis and die because you're immunosuppressed? So this is really just a short-term thing. It's not going to be lasting forever. So we do the same thing. We take an X-ray and find out, if they have a regular dentist and if everything, if their mouth is healthy. If they have an abscess tooth that their dentist is watching, we will take it out because you can't watch it when you're immunosuppressed and going through a transplant. So those patients are usually a little bit easier. So in this X-ray, you can see there's not any fillings, there's no cavities, the roots of the teeth are all there, and that's the kind of patient we see for transplants. Sometimes they come in and it looks good, but when you take the smaller X-rays, you can see that there are cavities in several of the teeth here. So we would fix these before their transplant because it may be a while before they can get to a dentist. And sometimes a side effect of a transplant is dry mouth. Now, the dry mouth may not be forever, but it may be long enough for them to get into a dental problem. So we try to remove potential sources of infection and ensure optimal health. So that they're not so hard, they're like any chemo patient. But why can't they see their own dentist? Well, their blood counts may be low, and they might have a central line. And the central line can get infected from oral bacteria from a dental procedure. So we have access to their blood counts and to the oncologist, and we can make sure everything is okay. The other thing is timing. Depending on their cycle of chemo, when their blood counts are up and down, and we will be able to determine that better than their own dentist. Now, we also have oral maxillofacial prosthetics. So these are usually patients who've had surgery to remove a cancer in the mouth, and then we help to restore function and aesthetics. So here's someone who had a squamous cell carcinoma of the roof of the mouth, and this is actually the nasal turbinates. So anything that goes in the mouth is going to come out the nose, and this patient won't be able to speak because their tongue will go up into that hole. So Dr. Almordini, he's our specialist, he can make a denture that will fit and close up this hole. It's called an obturator, and it would mean that the patient could eat and speak again. Okay. Here's another big hole in the palate from a salivary gland tumor in a younger patient that has all their teeth. And so we make a specialized denture that's going to fill up the hole. And here's the denture in place, and nobody can see it. So the patient will be able to eat and speak normally, and no one would know that there's a problem. Now here's a patient that has no teeth, but we're able to put in some implants. Now we can't put in implants if someone's had radiation, because the bone is not healthy enough to have an implant osseointegrate. So this was a carcinoma of the sinus, and here is a denture with a plug to fill up this hole, and the implants will help it stay in. Now, an osteosarcoma is not treated with radiation, it's treated with chemo and surgery. So you can see that they've had part of their jaw removed, and this is a skin graft. You can tell because it's got some hair on it. And then some implants were placed into the graft, and has normal teeth and function. Oh, and then we do some facial prosthetics. Daphne, who makes her eyes, is also an anaplastologist. So here's a man who's had a basal cell carcinoma, and he's got this very old prosthesis that's discolored and doesn't look very nice. This is what he looks like without it. So all of this has been removed, and his upper lip as well. And here's his new prosthesis. So Daphne does a great job of she made the mustache to hide up the upper lip missing, and this blends in very nicely.